Well, it looks like everybody's here, or everybody who's important enough to be here is here, so we'll consider it that way. My name is Michael Ackerman. I'm from the National Library of Medicine, and it's my privilege to introduce the speakers and take questions and so on. The session is Cardiovascular and Diabetes Disease Management. And what I've asked the speakers to do is to take not to exceed 15 minutes, which will give us a few minutes between talks to answer questions from the floor. So, not to take any time, our first speaker is Sleepin Abdullah, and let me get my paper. He's a research fellow at the Center for Connected Health, and his talk is the impact of using mobile-enabled devices on patient engagement in a blood pressure remote monitoring program. Thank you.
All right, thank you, Michael. This afternoon, I'll be reporting on the results of the evaluation of one of our remote monitoring programs, specifically the Blood Pressure Connect program. So for the program, so what we did was, so we looked at the types of data transfer technology that we use in the program, and we're trying to see how these devices affect patient engagement in the program. As a background, the prevalence of chronic disease are rising, not just in the US but globally. We see that diabetes, hypertension, obesity, and heart failure are rising. So this rise is fueled in part by the fact that we have rapid population growth, and the fact that we also have advances in medical science that help people with chronic disease to live longer. So they live longer, but the fact that people now live longer, so we have a very, very large people with these diseases. So hypertension is a silent disease. It's silent because it doesn't manifest until someone has a major complication in one of the end organs. Hypertension, according to the American Heart Association, accounts for about 69% of those who have a first heart attack, 77% of those who have a first stroke, and about 74% of those who have the first heart failure. Like someone said, patients are the largest healthcare workforce out there. We see that these diseases are rising, but the healthcare workforce, the number of doctors that we have, the number of nurses that we have, are not rising proportionately. And if you look at the care activities on a care plan of someone with a chronic disease, 90 to 95% of these activities are meant to be performed by the patient himself. So we see that we need to tap into these huge resources that we have in patients. We need to empower them to be able to self-manage their own disease. And for many chronic diseases, there are many disease management programs that are out there. For hypertension specifically, home blood pressure monitoring is a recommended self-care behavior that has been shown to correlate well with outcome and actually help people with hypertension control their blood pressure. In almost all of the sessions I've been to at this conference, and in many other previous meetings I've attended, I found the topic of patient engagement is almost everywhere. Everyone out there is looking for what is that thing in programs that can actually help people to engage in a program. Because for any of our disease management programs to work, you want the patient to comply with what you're telling them to do so that they can actually use the device and actually achieve good outcomes. A number of factors that influence patient engagement, as described in the literature. We see that the effect of the disease, the knowledge about the disease, and relationship with care providers are very, very important. For many of our programs, we found that we found feedback from many of our patients. They told us that the fact that they know that their provider is looking at their data to see how they're doing, the fact that they know there's someone looking at how well they're doing on the other side makes them want to engage more in the program. The technology also affects patient engagement and other program specific factors. So the Blood Pressure Connect program at our center is an hypertension self-management program that helps people with hypertension to be able to self-manage their disease. And the program consists of three essential components. There is the patient component, in which we give patients a commercially available blood pressure device and a data transfer technology that they can take home to check their blood pressure. They send their readings to a database, a central database. This database has a display function that they can go online to see how they're doing, so they can monitor their trends and view their data and see how they're doing. On the provider end, providers can also log on in front of their computers and see how their patients are doing. We've achieved a lot of success with this program. The program has been existing for the past 7 years at our center, and the program has now been integrated into the electronic medical records. A recent evaluation of the program revealed that the program was associated with an overall decrease of about 6 millimeters of mercury in the systolic blood pressure, and the diastolic pressure decrease of 2 millimeters of mercury. So what we did, in our program, we use two main types of data transfer technology. So over there, we see the blood pressure device. So the blood pressure device relays data that are taken either with one of these devices. So the first device that we see up here, so this is a modem-based device that connects via a telephone line. It goes into a telephone line. So the patient has to sit down there, measure their blood pressure, and it transfers the data to our database. So the other type of program, the other type of device, which we recently started using, is a wireless-based device. So this device, they can be anywhere within the confines of their home and use their devices. So the question we sought to answer from our evaluation was, does the type of device used by patients in this program affect their participation in the program? So for our methods, what we did was, we did a review of our database for a 6-month period. So after we've excluded those who had been in the program for less than 2 months, and those who were participating in a pilot or a clinical trial, we had 30 patients who were matched by age and by practice. Half of these patients used the wireless devices, the other half used the modem-based devices. So for engagement, we looked at the time to first reading, the time to first upload. We also considered the frequency of measurements, the frequency of uploads, and finally, we looked at frequency of help desk calls for troubleshooting. So we found that those who use the wireless devices actually engage more. Go back. Yeah, so those who use the wireless devices, they engage earlier in the program. We also found that those who use the wireless devices, they use their devices more frequently. And finally, we found that those who use the modem devices were more likely to call the help desk. So within the first 30 days of enrollment, go back, please. Yeah. Within the first 30 days of enrollment, we had 7 out of 15 people call the help desk to troubleshoot their device or tell us they have a problem. And by the end of the 6-month review period, this number had risen significantly to about 10 out of 15 calling the help desk for those who use modem devices. So as we begin to think of developing new programs to help self-manage for different chronic diseases, be it hypertension, be it diabetes, we need to begin to think about what kind of devices we want to use and how these will likely impact the patient and our workflow within the office setting. So finally, we summarize that instantaneous transmission of data made possible by wireless devices from our program, we see that this facilitates timely feedback on the part of providers and also help the patients to engage more in the program. All right, thank you.
Don't go away. Are there questions? You all satisfied? Okay.
All right, thank you.
Thank you. Okay. Our next speaker is Lorraine Buis, and she's an assistant professor at Wayne State University. And her talk is evaluation of an SMS medication reminder system to improve medication adherences in African Americans with uncontrolled hypertension.
Hello everyone. Today I'm going to be talking to you about a system that we've developed in Wayne State University. A lot of people today are talking about third-party vendor systems that people are using, but this is actually a homegrown system that we have here in Detroit that we've been using with an uncontrolled hypertensive population. High blood pressure is one of the most common problems that we face with chronic disease, and we know that approximately 68 million U.S. adults have high blood pressure. It can lead to coronary artery disease, congestive heart failure, and stroke, and the costs associated with high blood pressure in the U.S. are particularly high. In 2010, it was estimated to cost the U.S. approximately $94 billion in health services, medications, and days of work missed. The burden of high blood pressure in the city of Detroit is particularly high. And the city of Detroit, as many of you probably know, is a largely African American population. 83% of the population of Detroit is African American. And high blood pressure disproportionately affects African Americans. Approximately 33.5% of African Americans have high blood pressure as compared to about 28% of whites. In addition to there being greater percentages of people affected by high blood pressure within the African American population, the control is also worse among those who are treated. Of those with high blood pressure, only about 44% of African Americans have control or have their high blood pressure under control, whereas 56% of whites do. In addition, we know that the average age of onset is younger in the African American population, and there's greater rates of stroke and cardiovascular mortality. And while we don't know exactly why the control is worse in the age of onset, and there's a lot of reasons that can contribute to this disproportionate effect and burden on the African American population, we can partially attribute these increases to poor medication adherence. So what can we do about it? I work in a very low resource setting, and I know from a lot of pilot data that we've collected, and I'm sure this is no surprise to you, that cell phone penetration, even among the poorest communities in the U.S., are very, very high. Everybody has cell phones, and they're using them for text messaging and other activities. So we set out to develop and test preliminarily a medication adherence reminder system. We set out to make the system to be completely automated so that it would reduce the resources needed to run it. And we had funding from the agency from ARC to develop this system and to test it. So in phase one, I'm not going to spend much time talking about the development of the system, but we used a lot of usability type testing. We used focus groups. We sat down and really talked with our target end users to get a good sense for how they use their cell phones, the problems that contribute to their medication adherence problems, and how can we use the cell phones to support medication adherence. The phase one system development is complete, and we've now moved into the actual evaluation portion of our study. We have two different settings that we are evaluating this system in. We're looking in a primary care setting within the city of Detroit, so we're working with different primary care clinics. And we're also evaluating the system within the context of an emergency department setting. In our city, like many low-resource settings, many people seek out primary care treatment from emergency department settings, and we find that that's a particularly large problem in the city of Detroit. The number of people who are going into the ED for things like medication refills for their blood pressure meds, it's very high. So if we can find a way to alleviate some of the burden on that emergency department, we're looking to see are there ways that this type of system can help. So what have we developed? Well, we have an automated reminder system, like I mentioned, where users can customize the frequency and the number of reminders that they receive every day. We have people with very varied schedules, so clearly people will want to receive reminders at different times. Some people dose once a day, twice a day, 3 times a day. There's just a whole lot of dosing regimens that you need to account for. So we've developed a fully customizable reminder system. Based on our focus group feedback that we heard from target end users, incorporated twice weekly health promotion messages regarding things such as diet, physical activity, smoking cessation, high blood pressure, and weight loss. That was something that people really wanted to see, these types of health promotion tips come across their cell phone. We've also incorporated a weekly one-item interactive user satisfaction questionnaire to gauge what people think of the system as they go through our intervention. So as I mentioned before, we have 2 different settings that we're testing this system within, and both evaluations are the same size, the same scope. It's just we're varying the setting. We are working with a 2-arm randomized controlled trial design. We are recruiting approximately 60 individuals that are randomized equally between the intervention group and a usual care control. And we have a very short follow-up period, and there's a couple reasons for that I'm going to get into in a few minutes, but we have a 1-month follow-up period. So we recruit and enroll, they use the system or they don't, and we follow up with them 1 month later. The primary outcome measure for our studies are medication adherence, and our secondary outcome measures are medication self-efficacy. How well do people believe that they can adhere to their medication regimens? We're also looking at blood pressure, and we're looking at satisfaction. This is largely a development-oriented study, but we want to see feasibility and acceptability also amongst our users. And so before I get into some of the preliminary findings, because both of these small RCTs are still ongoing, I want to talk a little bit about the challenges that we've encountered in working in low-resource settings for mHealth research. These problems that I'm going to talk about focus on issues of recruitment, enrollment, challenges with mobile phone carriers that are typically used amongst these lower income populations, and participant retention, which that's not a problem that's unique to mobile health studies. In this type of setting, in low income settings, participant retention is always a problem. So in terms of recruitment enrollment challenges, there are costs associated with text messaging for many of the participants who want to enroll in our studies. While text messaging is something that is just included in my plan on my cell phone, it's not something that's included in all of the plans for our research participants. And in order to combat that, we have provided for reimbursement for cell phone text messaging. We also find that some individuals on some of these lower income targeted cell phone plans don't have text messages at all in terms of a quantity that they can send. Rather, it detracts from the minutes that people have within their plan. And that's a problem if you have very limited minutes and you're in a type of intervention that's sending you 1, 2, maybe even 3 or 4 text messages a day. So we reimburse rather generously. We reimburse up to 20 cents per text message if unlimited text messaging is not included in your plan. While my cell phone carrier has a very low cost for text messages, some of these lower income targeted providers, their text messages can be quite costly. We've also found that there's a participant lack of trust with the research process, which again is not unique to mobile health research, but it is something that we have certainly encountered in our evaluations of this text message system. In order to combat that, we have been trying to piggyback with other cardiovascular and hypertension related research projects that are ongoing in the city of Detroit, at least for the emergency department setting that we're working within. So we have a flow of different research projects that if you're interested in participating in, you start out with eligibility criteria for the most rigorous. If you are not eligible for that, then you're screened for the next one and then the next one, and we are in that queue of research studies that you could potentially be recruited for. We also recruit within both the emergency department at the Detroit Medical Center at Detroit Receiving Hospital, but we recruit directly within the clinics that we're working with. We find that that helps increase the trust that the participants have because they know that their physicians know that we're there in the lobby recruiting. And we've also tried, to the best of our ability, to utilize direct provider referral whenever possible. We suspect that that has some of the best payoff, but it's really hard to get providers to want to work with us when there's so much that they have to do already within the context of their clinical relationship with their patients. We've also encountered a lot of problems with the limitation of various recruitment strategies within this low-resource setting. Advertisements work great for drumming up interest, like flyers in clinic lobbies and in exam rooms, but the minute you mention that there may be some type of incentive, or people kind of figure that there might be an incentive for their time, everybody has high blood pressure. Everybody. So we find that that's really not a good strategy for reaching our target population. The same goes for snowball sampling. Once your brother gets into this research study, everybody in their family has high blood pressure and wants to get involved. So that's been a real challenge. Letters, we've sent out more letters than you can imagine to people that we know have high blood pressure and problems with hypertension, but they have very little yield for getting people enrolled in our study. We don't know if that's because people aren't actually getting the letters, whether they're not reading the letters. The letters do come from their physician's office, but we've had a tremendously low yield of a return on investment for the letters that we've been sending to our target population. And again, direct provider referral, we suspect, is probably what yields the best return, but getting providers to actually work with us to recruit participants is really difficult. We've done what we can to make it as less burdensome as possible on providers. We have tear-off sheets that they can give to people who they think might be eligible based on our clinical criteria. We have pamphlets that they can distribute. You know, we've done everything that we can to kind of alleviate that burden. But again, it's just really hard for providers to take the time to talk about a research study within the context of the few minutes that they have. We've encountered several problems with some of these mobile phone carriers that do target the population of our interest. SMS short code messages tend to be blocked on a lot of these plans, and working with certain providers, like one provider in particular that we had a lot of problems with is Metro PCS. And Metro PCS is one of the largest mobile phone carriers in the city of Detroit. And getting them to remove our short code from their blocked sender list or to put it onto their list of, quote, premium services that are allowed, it took some time to get through that roadblock. There's also a couple of government subsidized plans that we've encountered problems with, and we've had to find offline hacks, such as, you know, sending things through a web-based provider that will be sent as a different type of message, and try to circumnavigate some of these roadblocks that have been put in our way has been a real challenge. Again, I talked briefly about the cost of text messages that we're reimbursing for. And the stability of phone numbers. A lot of our participants don't keep their numbers for very long. I wouldn't say it's the majority, but it is a sizable proportion of people who share phones, who buy minutes and then ditch a phone, and this contributes to one of our rationales for having such a short follow-up period. And lastly, participant retention challenges. Again, these are not limited to mobile health studies, but persistent contact has been really key at getting our participants to come back for our studies. We talk to them several times throughout the 1-month period to ensure that we're going to get them back in to get their follow-up data. We incentivize both the follow-up and the baseline data collection, and we are extremely flexible when people want to meet. I'm not kidding. We have a 2-hour window that we have to allow because people will show up 2 hours early for an appointment if they're relying on public transportation and they don't want to miss it. The bus system in Detroit's pretty bad. Preliminary results, I'm running out of time. Primary care, we've enrolled and randomized 28 individuals and completed 19. In our emergency department, I don't have a good number of how many we've screened, but we've enrolled 38 and completed 32. We've only lost 4 to follow-up in the ED, and we've lost none to follow-up in the primary care setting, which I think is a minor miracle. Preliminary data, I'll let you look at that real briefly. Mostly female, approximately 51 years old. pretty low income setting. We really do carry the big, broad spectrum of users, and not many people have prepaid cell phones. And as I'm out of time, I just want to follow up, or to finish up and say, we're not finding much effect yet. But I still have hope that we may find an effect. As you can see, we've only gone through, in the primary care setting, not even quite half of the people, and only a third have completed. And even though we haven't found an effect, we're seeing a trend towards an increase in the intervention group for improvements in medication adherence. Acknowledgements, and if anybody has any questions, I'd be happy to take them now.
You mentioned that ARC was providing funding.
Yeah.
The population you were targeting didn't have mental disabilities, did they?
No, that's not an inclusion criteria.
Second question, why do you think the providers have such a low referral rate when this would have helped with patient wellness?
I think because they're hammered with seeing patients. I mean, I go into the clinics and I see waiting rooms of many, many, many people waiting to be seen and treated. And so I think that the context of the clinical encounter is very expedited in regards to that in and of itself. Getting through all the patients' loads that they have, particularly in the ED, it's hard. What do you mean, can you schedule?
Specific times?
Yes. Yep. Yep.
And then was this something that you developed yourself?
Yes. Not through ARC support, through the Wayne State University Department of Computer Science. We piggyback off of the emergency broadcast system at Wayne State University. So the system that's already in place for sending out emergency alerts, we piggyback off of that short code. No, we have not. One of our inclusion criteria is that individuals have to have uncontrolled hypertension, and so we are getting lists of individuals through electronic medical records with the clinics and the hospitals we work with that we know are already clinically eligible, and then we're going from there to try to get a hold of the individuals to participate. Again, when we try those methods in our setting, everybody has high blood pressure. And then establishing uncontrolled high blood pressure on top of that is more of a burden than we're willing to. Oh, I see what you're saying. No, we have not tried those methods.
One more, last question here, and I'm reminded by the folks, not now, if the next speaker, if you have a question, use the microphone. But let's complete this round.
Are you using a particular strategy to be sure that when the patient gets the text, it's in close proximity with the medication?
At this point, no. Again, most of this study has been really focused on the development of the system and then the preliminary testing of the acceptability and the feasibility of its use in our population. That's certainly a next step to try to look at. Okay, thank you.
Thank you so much. So now we come to the third talk, and it's by Dr. Alexander Logan, Professor of Medicine at the University of Toronto. And his presentation is the effect of home blood glucose telemonitoring with self-care supported on glycemic control in pregnancy. Doctor?
Thank you. Thank you very much. I'm the RCT guy that the engineers love to hate based upon Dr. Cafazzo, who leads the technology development of our program. By way of introduction, these are the members of the healthcare team. By way of introduction, good glycemic control will reduce maternal, fetal, and neonatal complications associated with uncontrolled diabetes and pregnancy. Self-monitoring of blood glucose during pregnancy is recommended by current practice guidelines, and mobile technology linking patients with clinical teams has the potential to greatly improve healthcare delivery. Our telemonitoring system is outlined in this slide. It is patient-centered. Whatever. Yeah, patient-centered. And the patient measures the blood glucose. The glucometer is Bluetooth enabled, and it is paired with the phone, and this information is sent to our data service for processing, messaging, and storage. The results of the readings is displayed on the phone right here, along with an action message. Messages are based on care paths defined by running averages of transmitted readings. Patients who are not adherent to preset home blood glucose monitoring schedules trigger an automated voice message that is sent to the patient's phone, requesting them to check their smartphone for a message. Critical alerts are automatically sent to the patient's provider whenever blood glucose exceeds a predetermined threshold value, either high or low. Simultaneously, an automated message is left on the patient's home phone, advising them to check their smartphone for a message, which instructs them to check for a message and contact their healthcare provider. Both patients and healthcare providers can visit the secure website. Right there. And all blood glucose readings, messages, trends are stored on the web thing. The advantage of the telemonitoring is outlined here. It's better than standard self-monitoring of blood glucose, such as poor adherence with testing, data accuracy, and perceived futility by patients. There's real-time transmission of messages, alerts, and reminders. Information is transferred, does not require transferred automatically, and doesn't require a fixed telephone network or internet. There's full automation and simple to use and immediate access, and provides healthcare providers with easier access to patients' blood glucose readings, thereby assisting them in formulating and altering management and treatment strategies. This is the flow chart of subjects participating in our study. We had 571 pregnant women that have come to the prenatal clinic, and they were assessed for eligibility. Of these, 101 individuals were agreed to be randomized, and they were randomized 51 into the telemonitoring group and 50 into the control group. Reasons for non-participation included ineligibility, lack of interest, and failure to follow up after expressing interest initially. At the end of the study, we had 4 dropouts in the telemonitoring group and 7 dropouts in the control group. The study methodology is outlined here. The duration was from the time of enrollment to delivery. Daily glucose testing was recommended, 4 readings per day, fasting, and this should be after meals. The control group had standard care, maintained a logbook with self-recorded results. The telemonitoring group, as mentioned, had instant messaging and adherence reminders and alerts both to patients and to the providers. This is the baseline characteristics of the study subjects, 80% of the individuals had gestational diabetes, and the maternal age is approximately 35 years. Gestational age is not years, but no woman get pregnant, but rather at 26 months or 26 weeks. And blood pressure at enrollment was, BMI at enrollment was 28. These are the weights in kilograms, and about 10% of the women had chronic hypertension. These are the mean readings per day of all subjects as recommended. 4 readings per day was recommended. In the control group, the mean was 3.3, and in the test group, it was 3.7, and the difference was statistically significant. In addition to that, the distribution pattern was markedly different between the controlled subjects and those who had in the test group, and the number of subjects with 3 or more readings per day was significantly higher in the test group than in the control group. This is the data for the gestational group only, and one sees the very same type of distribution pattern, and again, this bunching up of readings in the test group compared to those in the control group. And the difference between the control and test was statistically significant in this subgroup. These are the mean blood glucose values as an outcome measure. There are many factors that can influence blood glucose values, including the type of diabetes, whether they're on insulin, BMI, weight gain, maternal age, and what we were really trying to test for is whether there was a group effect. So taking all these factors into consideration in multivariate analysis, thus controlling for all these factors, one can see that being in the test group was associated with a significant reduction in blood glucose compared to the control group. In the gestational diabetic group, there was trend, although not statistically significant. And it just highlights the data there. Other outcome measures are shown with the parameters listed here. Weight at delivery, weight gain, birth weight. There was no significant difference between the two groups. And similarly for maternal and fetal outcomes, there was no difference between the two groups. The major reason is that the sample size is small, and we're really looking for, as a primary outcome variable, change in mean blood glucose, not any of these parameters. So in summary, diabetes and pregnancy, there was changes in the telemonitoring group versus the control. They had a significant reduction in blood glucose in the type 2 diabetics with a trend in the gestational diabetics. There were more readings with an increase in both gestational and the type 2 diabetics, and there was no difference in weight gain between the two groups. These are the individuals that participated and made this study happen, and we had financial support from the Ontario Ministry of Health and Long-Term Care, and the smartphones were provided by Research in Motion. Thank you. If you have a question, please use the microphone. They'll make sure it works.
Okay. Thank you for the presentation. 2 questions. I'm assuming that providers knew who was in the control group. Were there differences as far as education and education provided to patients who were in control versus test group? So did providers provide more prompting to get blood pressure measurements done at home for control group?
We couldn't monitor exactly what the interaction was between the healthcare providers and the women. So it may be possible that they knew that there was a difference because they were the ones, they were the recipients of having all this information on on their computer screen when they saw patients.
And the second question is, the 3.2 versus 3.7, it is a difference, but do you think that was the sole explanation for the significantly better blood glucose control for the test group, or were there possibly other factors?
I think it is, primarily because we looked at all the different factors that we did univariate analysis of all the factors that might influence blood glucose levels, and you could see there were a whole list of factors that would alter blood glucose values during the course of a pregnancy. We controlled for all those factors that were significant. They were put into the multivariate models, so they were all controlled so that we could specifically look at just the test group versus control.
It's Mika Scripps, Health San Diego. Quick question on if you looked at cost or other process measures. I wouldn't have expected big differences in glucose outcomes since whoever's providing for them is probably pretty neurotic about taking care of their blood sugars. But did it make it easier? Did it cost less time spent? Any of those things in the group that had the intervention?
We didn't do a formal cost analysis, but I think you bring up an excellent point in the fact that 80% of the participants were gestational diabetics. These were individuals that had not experienced being a diabetic, or as soon as the pregnancy was over, if they had gestational diabetes before, the diabetes would go away. So they became very obsessive in monitoring, and that may well be why we didn't see as much of a difference in the gestationals, whereas the people with type 2 diabetes, they've had diabetes not only during the pregnancy but between the pregnancy, and they were taking a more, maybe somewhat more casual approach to blood glucose monitoring. They weren't as concerned if their blood glucose was as high or as low during pregnancy. So that's probably why we were seeing a greater effect in those. So in looking at this, one would say that this intervention should be targeted at more difficult to manage patients than those individuals that are highly compliant. And so therefore it's probably not a good intervention for the gestational diabetics, because I don't think there's a lot of value added for the gestationals. But it certainly makes a difference for the type 2s. But we didn't do a formal cost analysis.
Thank you so much.
Okay.
And the last speaker of this section is Dr. Moi Tian. Dr. Tian is a research fellow at the Beijing University Health Sciences Center. Next slide. Laser. Okay, thanks.
Good afternoon, everyone. Thank you for giving me the opportunity to present here. What I'm going to present to you today is currently ongoing study that being implemented in Tibet, China, about an electronic decision support system for cardiovascular disease management in that kind of limited resource settings. Just to acknowledge that the George Institute for Global Health at Peking University Health Science Center was previously known as the George Institute for Global Health China. So as many of us may already know, that the cardiovascular disease has been regarded as the top #1 cause to death in both developed and developing countries. And an estimated of 17 million people die from cardiovascular disease every year. Over of 80% of these deaths occurring in low and middle income countries like China or India. A study assessing the overall hypertension in the whole population in Tibet, which including both rural areas and urban areas, up to almost 15% of the population was found to be hypertensive. And the other study, which focusing on the old adult population in rural areas, the prevalence of hypertension is as high as nearly 56%. So there's many well-established intervention protocols which can help to reduce the cardiovascular disease burden. And such intervention are like lifestyle modifications of known risk factors and the prescriptions of effective and low-cost medications. However, one particularly cost-effective approach is to identify and manage the high cardiovascular disease risk patients in order to delay the event. This kind of approach has been applied in many large-scale studies in both China and India. But the question is how to extend these current solutions to the areas with very limited economic and healthcare resources. And we expect this kind of strategy has to be simplified, effective, and affordable due to the local characteristics. So the SIMCAR study is short for the Simplified Cardiovascular Management Study. It is a cluster randomized control trial, which is currently being conducted in Tibet, China, and Haryana, India. The overall goal of this project is to develop pilot test and evaluate a highly simplified but guideline-based program for cardiovascular disease management in very limited resource settings. So before a baseline survey will be conducted before the project to screen out all the high-risk patients. Then all eligible high-risk patients will be randomized into either the intervention group or the control group. The patients in the intervention group will receive 1 year-long intervention delivered by the community health workers, and all the other patients in the control group will just receive the usual care. After 1 year-long intervention, all high-risk patients will be invited to participate in a post-intervention survey. So the selection criteria of the high-risk patients is based upon the subject's age, disease history, and the blood pressure measurement at the day of the baseline survey. The intervention model is named as a 2+2 model, which refers to 2 lifestyle modifications, including the smoking cessation and salt reduction, and prescriptions of 2 types of CVD risk-lowering medications, aspirin and low-dose diuretics. So basically, the SIMCAR China project, we have 2 study sites. One is in the eastern part of the Tibet region, called Gongbu-Jiangda, and the other one is called Linzhou, which is very close to the capital of Tibet region, Lhasa. So the project was launched in here from January this year, and all community health workers participating in this study were trained to use a paper-based clinical measurement record form to manage their high-risk patients. Before the project was launched in the other study site, we encountered some very challenging problems, such as the community health workers can't really follow the standardized protocols to manage the high-risk patients. And due to the very limited education background of the community health workers, it's pretty hard for them to follow the logical things on the forms. And there's a lot of missing data on the forms as well. So we decide to do something like innovative or like something different. So before the project was launched in Linzhou, we did a short survey to all the community health workers who are participating in this project from both study sites. And all community health workers are willing to accept some new technology to manage their high-risk patients. And the good thing is all the community health workers in these two study sites have a mobile phone. And however, not every mobile phone is a smartphone. But surprisingly, the good thing is the mobile reception is much better than we thought in Tibet region. Over 80% of Tibet were well covered by the mobile reception. So we decided to develop an electronic decision support system to be incorporated in this study. The electronic decision support system is a smartphone-based application that aims to assist the community health workers better follow up the high-risk patients on a monthly basis during the 1-year intervention period. The application consists of probe regarding to the patient's medical history, new conditions, medication use, lifestyle habits, physical examinations, and appropriateness of prescribing of CVD risk-lowering medications. So the application development was collaborated with China Mobile, the largest communication company in China. And once the community health workers collected all the data from the field, the data will be sent back to a secured central database. The project research team will go through the database to conduct regular quality check and can also to generate some key performance indicators to the community health workers. So this slide shows the algorithm for developing this kind of application. It's pretty busy, so I won't show you the details of the application of the algorithm. But I want to show you today is a simplified schematic diagram, which can cover all the key informations in this application. So basically, before the CHWs, the community health workers, starts to do the follow-up, the community health workers will retrieve the patient's information based upon the patient's unique identity number. And the community health workers then will ask for if the patients will have some severe symptoms in the past months. If there is, the patients will be suggested to be referred to a higher level hospitals. If there isn't, the community health workers will give some lifestyle recommendations. And an automatic decision will be made on which medications should be prescribed according to the new conditions, medication use, and the blood pressure measurement collected from the subject. So here shows you some screenshots of this application. The first one here is basically to retrieve the subject information. And second one is shows the severe symptoms for referrals. And this one here is to ask the patients if there is any new conditions developed and the lifestyle habits. And the screen here shows like the medication used in the past months and if there are any side effect associated with taking this medication and the blood pressure measurement, and finally there will be a decision making on which kind of medications should be prescribed. One of our study sites, GBJD, they use both the paper form and the electronic-based intervention delivery format. So we did a very preliminary analysis in terms of the follow-up rate in this study site. So we found an increasing pattern of the follow-up rate after the electronic decision support system has been applied in this study site. So as I said, this project is still undergoing, so we don't have any study outcome to show to you today. So what I want to show you is the current status of this project. The electronic decision support system application was applied to all community health workers in June this year, and the training has been done simultaneously at the same time. The electronic decision support application will be used for 1 year long until approximately the end of July next year. And we had conducted one process evaluation this August, and there will be another one to be conducted this month. So what's the significance of this study is this sub-study is the first study of the with an electronic decision support component for community health workers to manage the high cardiovascular disease risk patients in China. And we also want to use this study to evaluate the feasibility of this innovative and multidisciplinary program in community health workers, capacity building, and medical decision support. So what is our future work? So this mHealth system is basically our ultimate goal, and it will including two perspectives. One is from the healthcare provider's perspective, and the other one is based on the patient's perspective. If we look at the box here, the yellow highlighted content are basically the functions which has been developed in the current application, and all the others is basically we planned to be included in our future studies. And also in our future studies, we want to incorporate the mHealth system to be used from the patient perspective. For example, like to remind patients taking the medications on time, and there will be some interactions between the patients and doctors, and probably there will be some educational material will be included in the whole system as well for lifestyle recommendations. And finally, I would like to thank you, the collaborators for the China project, Tibet University, China Mobile Research Institute, and the University of Oxford to help us to develop this application. And finally, to thank you, the funding agency, the National Heart, Lung, Blood Institute, and the United Health Group, Chronic Disease Initiative, to support this study. Thank you.